You know, when we think about a rhinoplasty, a nose job, our minds usually jump straight to the surgery itself, right? But what's fascinating is that the most critical part of the whole thing, well, it happens way before anyone even steps foot in an operating room. Today, we're diving into the incredible art and science of patient assessment.
And this quote, it gets right to the heart of it. A surgeon can perform a technically flawless procedure, a real masterpiece. But if the patient isn't in the right headspace or has totally unrealistic expectations, that result is still seen as a failure. And that is the central challenge here.
So to get around that emotional dissatisfaction, the whole assessment process has become this deep analysis of the entire person, their psychology, their facial structure, and then only then the nose. It's really about understanding the why just as much as the what.
And that leads us to the modern framework for how this all works. It's really a three-part investigation into the patient as a whole person.
These are the three pillars that guide basically every single decision. First, and you got to hear this, most importantly, is the patient's psychology. Second, a holistic look at the entire face. And then, coming in third, is the detailed technical exam of the nose. So let's break each of these down.
Now, probably the best way to see how these pillars actually work in the real world is to imagine two totally different patients that a surgeon might meet.
So, on one side, you have Sylvia. She's what you'd call the ideal patient. She's well-adjusted, she knows what she wants, her goals are realistic, and she's just looking for a nose that fits her face. But on the other side, you have the difficult patient. This person might be really vague, or they'll bring in a picture of a celebrity with a completely different bone structure, or they're just fixated on some tiny millimeter-sized detail no one else can even see. A surgeon's first job is figuring out which one of these people is sitting across from them.
Okay, so let's dig into that first and most crucial pillar, psychology. This is the ultimate screening tool, because really, no amount of surgical skill can fix a problem that isn't actually about the nose to begin with.
So what are surgeons looking for? Well, there are some pretty immediate red flags. A patient who is just obsessed with surgical jargon, has a whole history of being unhappy with other procedures, or, and this is a big one, believes that changing their nose is somehow going to fix their marriage or land them a new job. These are all signs that the desire for surgery might be covering up something much deeper.
And this leads to the most significant condition that surgeons are trained to spot, body dysmorphic disorder, or BDD. We're not just talking about being unhappy with a feature here. This is a consuming obsession over a perceived flaw that to everyone else is either tiny or completely non-existent.
And here's the crucial part. For someone with BDD, the problem isn't in the cartilage or bone of their nose. It's in their perception. Operating on these patients is never, ever the answer. In fact, it can make things much worse. The only right move is a referral to a psychologist.
And there are other high-risk traits on the surgeon's radar too, like the extreme perfectionist, because, let's be real, perfect symmetry is a total myth in human anatomy. Or the patient who's just trying to please a partner. Even someone who swings between being overly flattering and then super demanding. These are all signs that a patient may be literally impossible to satisfy.
Alright, so once a patient is considered psychologically suitable, the focus finally shifts from the mind to the physical canvas. It's time to analyze the face and the nose. But, again, probably not in the way you'd think. You know, one of the first things a really good surgeon does is manage expectations. They'll actually point out that nobody's face is perfectly symmetrical. So if you create a ruler straight nose on a face where, say, one cheekbone is a little higher than the other, it might actually look unnatural and kind of off. It's all about harmony, not perfection. Next up is skin. And this is a huge deal. If a patient has thick, oily skin, they're just not going to get a tiny, super defined nasal tip. Why? Because the skin itself acts like a thick blanket, hiding all the delicate work underneath. On the flip side, really thin skin is totally unforgiving. It'll show every single little edge of cartilage after surgery.
Now, here's how surgeons look at a crooked nose. They don't see it as one problem. They see it as three. They systematically break it down into thirds. The bony upper part near your eyes, the cartilage in the middle, and then the lower tip. Each of those sections needs a completely different approach, so this analysis becomes the foundation for the whole surgical plan.
And the level of precision here can be kind of surprising. When they're figuring out how far the tip of the nose should stick out, they call it projection, surgeons actually use a mathematical ratio. The ideal projection is about 0.55 to 0.6 times the length of the nose. It's literally a formula for creating facial balance. But all the math in the world doesn't mean a thing if you're only looking at the nose. A great surgeon will always look at the chin. Why? Because a small, weak chin can throw off the entire profile of your face, making a perfectly normal nose look way too big. In a lot of these cases, the right answer isn't a nose job at all, it's a chin implant.
So after that deep dive into the patient's mind and the super detailed anatomical analysis, how does all this information actually come together into a concrete surgical plan?
Well, it's all synthesized using a pretty specific toolkit. It starts with a visual inspection, of course, but also something called palpation. That's literally feeling the strength and shape of the cartilage. Then comes standardized photography, computer imaging to simulate potential results, and finally, super meticulous documentation of the entire plan.
And those last two tools are so important. Think of it this way. The photographs create the literal map for the surgery itself. But the computer imaging, that serves a different, crucial purpose. It's a communication tool. It's how the surgeon and patient can finally get on the exact same page about what the goal is, making sure there are absolutely no surprises. It's the final and maybe most important check for managing expectations.
Which really brings us full circle back to this central idea. The entire exhaustive assessment process is designed to move away from this dangerous idea of a single perfect nose. Success isn't about hitting some abstract ideal. It's about creating the right nose that fits the unique face and, just as importantly, the realistic expectations of the right patient.
So I guess that leaves us with one last question to think about. In this complex art of rhinoplasty, is the perfect result really found in the precise shaping of cartilage and bone, something you can measure in millimeters? Or is it ultimately achieved in the mind of a well-informed, psychologically ready patient? All the evidence seems to suggest